The first presenter will be Dr. Udunna Anazodo. She's a physicist at the Neuro. She's a PET MRI physicist. She initially trained as a nuke med technologist and then switched to physics. Did most of her work at Waterloo in Ontario. And we were very happy to entice her to come to our place 3 years ago, where she's now our principal PET physicist, working on reconstruction algorithms that are specialized mostly with the view to reconstruct without transmission images, to do away with CT or anything of that nature, and using only the images from the emission. Dr. Anazodo is not here today. She's in Abuja. She's from Nigeria, and she has been working extensively with helping African countries get equipment for doing MR and PET scanning. So she travels quite a lot, I must admit. When you give her a date for something, she'll generally do it, but you don't know where from she'll do it. So I'm very happy to have her talk to you about imaging the brain and mind with PET MRI.
Thank you so much, Jean-Paul. Can everybody hear me in the room? Yes? Okay. So, yes, I am here in Abuja, Nigeria, and it's fantastic to be here. I'm going to talk a little bit about imaging the brain and mind with PET MRI. But before I get into that, I'm going to say one of the reasons one of the reasons why I moved to the MNI. I did my training at University at the Lawson Health Research Institute. And there we had a PET MRI. So I'm going to show some of the work that we did there. I'm sure some of you from Lawson, I know Dr. Lee gave a talk a couple of days ago. So I wanted to start off with this sign that's outside of the neuro that said the problem of neurology is to understand man himself. And this is by Walter Penfield. And Dr. Penfield did see the brain as an organ of destiny, and there's this humming mechanism that he believes lies deep into the brain that we, using imaging, can be able to discover, and that's what I'm going to try to talk to you about today. Can you guys still hear me? Yeah? Okay. So that's what I'm going to try to talk to you about today. So my lab essentially develops PET and MR methods. We look at this as very complementary. The idea here is to be able to really tie in that fundamental molecular imaging that we do well with PET, with a lot of the functional, volumetrical, and neurochemistry information. We do something like MRS with MRI. And we really build models that allows us to look at the brain, not just as a secular organ, but also as an organ that is attached to a system, which includes other systems in the body. So we try to do this system-wide. We have models for heart-brain connection, and we also do this within a global health context. So I'm going to focus a lot more on this quadrangle of what my lab does, which is building this PET MRI methods. And I'm thankful that Jean-Paul have kicked it off by essentially talking about some of the imaging technologies that we're developing at the BIC. For the past 5 years, my lab has been focused on really understanding neuroinflammation and how multiple different types of disease are essentially involved, contribute, or have contributions of neuroinflammation, and how we can image this using PET MRI. So I'm going to sort of highlight some of this, but the bulk of the work is how we do it and not what we do. I'm going to touch on how we were able to really do looking at neuroinflammation in the context of stroke, trying to understand how this impacts cognitive impairment, looking at neuroinflammation, especially focusing on translocator proteins. So we, at least most of these studies were done in Lawson, but at the BIC, we have the capacity to also do translocator protein imaging. So I'm going to show a lot of work that was done using FEPA, one of the agents that we use to image translocator proteins or neuroinflammation in the brain. And we've done this in the context of depression, dementia, renal failure, stroke. And we also have mice models that look at this heart-brain connection, both within a disease model like Duchenne, where we know that there's some impact in the brain, again, within the mind or context of cognitive impairment, and also within this idea of looking at ischemic disease from the heart level and how that affects the brain. We have done a lot of studies that look at this. All of these studies, we're able to do this because we understand that inflammation is not just a local, it's something that affects us systemically. And we now have really nice tools of how we image inflammation in the brain and also in the body. Translocator protein is something that my lab focuses on because we're able to look at microglia and macrophage using the same PET target. And that's one thing we're really trying to figure out how to do well, and even use MRI. So looking at something like diffusion tensor imaging to be able to tease apart some of this complex morphology that we tend to see when we look at something like microglia in the brain. We know that they take different types of morphology, and sometimes we're able to distinguish and disentangle this by including MRI imaging. Dr. Sosi has done a fantastic job introducing some of the technology that we have at the BIC that's allowing us to do this. One of this is the ability to look really deeply into the brain by using this ultra high resolution PET insert that we are working hard to get at the BIC to be inserted into a 7 Tesla MRI that will allow us to do really high spatial resolution imaging and tie it in with looking at very deep brain areas, like, for example, the hippocampus, which we're quite interested in. So being able to even image inflammation in the hippocampus. There's also ways of looking at inflammation across the whole body. So between organs like the brain and the heart, brain and the lung, brain and even muscle, for example, in Duchenne. We can do this with total body PET imaging, which again, we're really excited to have very soon at the BIC. But I'm going to focus a lot of my talk on the top part, which is looking at the brain, focused with this dedicated PET inserts, and also with the ultra high resolution PET only head only system. Let's moving on quickly. I'm going to focus a little bit on the two angles of where my lab comes in, which is the ability to really be able to reconstruct the PET images required from this high spatial resolution and novel emerging technologies, and being able to really quantify it in a way where we are able to know exactly what PET target we're imaging, moving away from doing semi-quantitative imaging, but trying to really enhance the parameters that we're pulling out from the PET images. So I'm going to give you a little bit of a preview of what we've done, trying to really reconstruct PET images very well using novel technology, including AI or deep learning, and a little bit on the analysis side, how we are now taking some of these images that are now well reconstructed, some of them are noise-free, and then really trying to pull out the parameters that we need to do parametric mapping, but non-invasively, so doing kinetic modeling non-invasively. So we've developed, or we're developing this tool thanks to funding from NSERC and also from the HPHL and FRQNT. We are trying to build a one-stop shop, and I'm going to work you through quickly through this one-stop shop method. The idea here is to have one solution, software solution, at all the users. So all of those people that Dr. Sosi showed that are interested in using our technology at the BIC, we want to be able to have a one-stop shop solution for image analysis, from reconstruction to analysis. This means that it doesn't matter where the PET comes from the insert that we're going to get from the ultra high resolution PET system or from total body PET. And it really doesn't matter where the MRI comes from, 3T, 7T, 1.5T. We're going to try to do is actually leverage all of that to pull out rich information from the MR. So using the MRI, for example, to do attenuation correction for some of these technologies that don't have a potential for us to do attenuation correction with CT. Using the same anatomical MRI to even look at motion correction, denoising. I'm going to show you some examples of that, being able to do partial volume correction. So it's essentially pulling all that anatomical information they're acquiring from the same subject, doesn't have to be simultaneous. And being able to really do a fantastic reconstruction and even kinetic modeling that's blood-free. So we're trying to do this one-stop shop solution, and I'm going to essentially give you a little preview of that. I think everybody in the room knows what attenuation correction is and the issue with PET. So I'm going to skip through this, but the idea here is that some of these PET-dedicated technology, like the PET insert going to the 7T, the ultra high resolution PET system we have now at the BIC that doesn't have a CT or any transmission source. The idea is to really use other mechanisms of doing that. And one way is either deriving it directly from the PET emission data that's non-attenuation correction, which we can do right now with AI, or using MRI to essentially derive that information. This is obviously not novel. We've been doing this for the past 10 years for PET MRI. The first attempt that we did in using MRI to do this type of pseudo CT or being able to generate attenuation information from MR has been well established on practically all of the 3 PET MRI integrated scanners out there, so GE, Siemens, and United. This is an early paper that was done back in 2015, demonstrating the need for being able to do this attenuation corrections very well, and the idea that if you don't, you're going to have PET values or PET information that's sometimes even biased up to 20%. And this is very crucial if you're trying to do quantification, especially looking at subtle changes in the brain or very small brain regions. So over the past 10 years, there's been a lot of efforts trying to really figure out how to do this well. Thanks to deep learning, there's been a lot of papers out there trying to really generate synthetic CT from MRI. Our group have done this like almost 5-6 years ago in 2019 at Lawson. This is an example of that, where we used anatomical T1 weighted imaging and build just a simple CNN network that allowed us to essentially create a synthetic CT from MRI. We've been able to validate this in an epilepsy study, where we essentially were trying to demonstrate that if you're able to image FDG, PET, clinically, these are clinical scans, that are, and you're using this deep learning based or let's just say really computational methods for generating synthetic CT from MRI, that you're able to get similar information. So essentially similar SUV values, similar Z scores or ZAI, so looking at asymmetry from the PET MRI done with a really good attenuation correction compared to PET CT. We're able to demonstrate that even on the PET MRI, that we can even take this information and get even more information about the epileptic lesion. So in this case, how well we can lateralize the lesion in cases where we have both of the parts of the brain showing very similar hypometabolism. This is essential for patients that are refractory and needing surgery. So we've been able to demonstrate, at least in the small study that we did at Lawson, that being able to do the PET really well with MR-based attenuation correction and now combining it with diffusion tensor imaging, which, for example, we're able to do because we have the PET MRI, that we're able to actually lateralize the brain in at least 50% of the patients very well and with histopathology confirmation. We've also been able to demonstrate that it doesn't really matter what type of deep learning, because there's very different flavors of deep learning. We did a systematic review and showed that through meta-analysis that some of the typical flavors of deep learning methods for attenuation correction, both those that are derived from MRI and those that are derived directly from the PET emission without attenuation correction, that these methods tend to give us very similar PET SUV values with reference to a CT, for example, or with reference to transmission scans for the studies that did the emission scan. So in general, we're able to now really do attenuation correction well for emerging technologies like the brain PET system or this dedicated PET-only systems. And so the idea is that hopefully by this time next year, when we have the PET insert in the 7 Tesla or the brain PET fully functional, that we can develop a one-stop shop. Again, doesn't matter if it's 3T or 7T or 1.5T, and really doesn't matter if it's just doing it directly from the PET. We're going to use a robust method to essentially create a way for us to be able to do attenuation correction. This is also very important because we're also trying to get into being able to denoise PET images, or being able to lower the dose for PET imaging. And so getting rid of the CT is actually something that we are really interested in doing, both for looking at pediatric or radiosensitive populations, but also for being able to do longitudinal imaging, or imaging that requires multiple tracers. And I'm sure Dr. Rosanetto is going to talk about some of his studies where he's doing tau, amyloid, and neuroinflammation. So one patient or one person getting multiple PET scans over multiple time periods, it would really, like say, important to get rid of the CT. And this is just essentially to demonstrate that we've tried to do this beyond the brain. This is something that we did earlier back in 2018. This was done by at the time, a PhD student, now a full professor, Claes Ledefode from Rigsted Hospital in Denmark. And the idea here was essentially using an even much more less robust method. So this is doing machine learning using random forest, and demonstrating that we can pull this out from Dixon MR. For those in the room that don't know, Dixon is just a 2-point weighted imaging that doesn't really give you really nice bone information. But even with that, we're able to, at least using some of these machine learning techniques, pull out really nice bone information from the MR. As I mentioned earlier, the idea here and what we're trying to do with this one-stop shop image analysis tools or image processing tools is also develop tools that are leading us towards low-dose PET. We've been able to do this in collaboration with Siemens, where we've actually started to look at ways of being able to pull in the MR information to guide how we regularize and reconstruct the PET images, so that we're able to actually, denoise the PET images really well. And at least if you denoise it very well, you're actually able to pull out signals or PET signals, even when you have very, very low count data. We've been able to demonstrate that. This is an earlier attempt that was done by a different group from Leuven in Belgium, where they were able to use a deep learning method based essentially based mostly on the MRI to guide the PET reconstruction. And here I'm showing their method compared to standard OSCM reconstruction on FDG. And they're again demonstrating that if you go from 20 minutes down to even a minute, so 3 minutes down to a minute, that you're able to still get really nice reconstructions. And this is, again, guided by MR. I'm just going to turn my highlighter on so you guys can see. That's not what I want to do. I want to turn this highlighter on. No, highlighter. Sorry, highlighter. Pointer, laser pointer. Yes, so you guys can see that. And again, if you kind of look at some of these deep learning methods, there's very little, will I say, difference in terms of from a quantification level when you compare it to standard OSCM. And that's really important because we don't want to have quantification being impacted when we're introducing things like anatomy to guide a PET reconstruction. We've also worked with Siemens. This is the work that we did, again, mostly done at Lawson, but something we're going to translate to the BIC, where we're, again, trying to come up with better ways of being able to use the MRI to guide the reconstruction, especially when we go very low, as low counts as 1 minute scan. And the idea here is when we start to do dynamic imaging, sometimes you go below a minute scan for some of these time frames. How are we able to still pull out the PET information to really do quantification very well? And we've been able to demonstrate that this is feasible. We're still working on being able to get below a minute, but it's very interesting to see that we can at least do this reconstructions well. Again, this is guided by MR. The MR doesn't have to be simultaneous from our own implementation. This is an example in an epilepsy patient. Again, this is the same patient I showed you earlier that had that dual. Can you guys still hear me? Because my internet seems to be unstable. Am I still okay? Can somebody give me some feedback to know how I'm doing? Hello, perfect. Okay, thank you so much. Again, I apologize for the internet disruptions. So this is one of those examples I gave you earlier. This is a patient that had what appeared to be earlier as slight hypometabolism. We were able to demonstrate with Z scoring or also with ZAI. So ZAI meaning the asymmetrical index mapping. This is the standard OSCM, a 30-minute scan. This is with MR guided. Sorry. Can you guys still hear me?
We hear you super clear.
Yeah? Okay, thank you so much. My internet just flashed again. So this is with the standard OSCM reconstruction for 30 minutes. This is with the MR-guided attenuation reconstruction at 3 minutes. This is, again, just with PSF or standard OSCM, and this is with MR-guided reconstruction with PSF. The idea here is that we're still able to pull out our epileptic focus, or what we call it, the ZAI, from the map reconstruction. And again, just to demonstrate that we've done this with amyloid scans, again, at 5 minutes and at 1 minute. Obviously, the 1 minute needs some work, and we're working on that, but at least demonstrating the fact that we're moving towards this idea of low-dose PET imaging. And I'm going to skip through this quickly for time. If you want to know about MR-guided reconstructions, there's lots and lots of groups that are doing this. There's pros and cons. This paper really summarizes that well. And the reader who used to be at the BIC, now I'm back at King's College, have really demonstrated some of the pros and cons of different types, because again, there's different flavors or will I say frameworks or models of deep learning that's been applied to denoising or sometimes low-dose PET. And you can read this paper for that. One thing we're trying to do, and this is a work that we've started at Lawson, we're going to move quickly to the BIC, is doing this entirely on the PET data, not really using the MRI to guide that. The idea is if we learn noise well and learn the noise distribution in PET data using deep learning methods, especially paying attention to how well the similarity between noise and signal is, that we might be able to get away with using MRI and essentially learn as much as we can from the PET and denoise. So this is a work that Raymond Confidence did in my lab for his master's, and moving it on to a PhD where we're trying to even be able to do this without having a fixed, will I say, dose target. So in this case, we did this for a 3-minute scan. So that's 10% of the injected dose and 90% dose reduction. The idea is to make this a bit more optimized based on the patient weight, the scanner physics, and all of that stuff. But for now, we're able to demonstrate, at least on static imaging in epilepsy patients, that we can get down to 3 minutes. So this is a 3-minute scan of an adult and a pediatric epilepsy patient versus the 30-minute scan. Now, when we do the standard deep learning methods that other people have suggested, which we've tried, this is one of the best, Our method, which we call SMART because it's similarity weighted, so we're actually trying to learn noise very well, tends to perform a lot better. We're still able to pull out the epileptic focus well on the same subject. And we've compared our method, so this is SMART, compared to then all these flavors of deep learning, again, with the 10% dose target, meaning that we're trying to demonstrate that we could at least reduce the dose by 90%. And we've been able to do this in multiple different cases. So this pediatric epilepsy, FTD, frontotemporal dementia, healthy volunteers, adult epilepsy patients. Our similarity index, some of the metrics that we use to see how well we can pull out this or reconstruct, should I say, the PET image by itself, non-denoised, also at a 90% dose reduction compared to a standard OSCM 30-minute scan. We get very similar information. For time's sake, I'm just going to, again, go to the other side of the quadrant, which is image analysis, to demonstrate what we're trying to do at the BIC, to, again, bring us all the way from PET MR, if you have, and I'm talking about anatomical MRI at this particular point, to help us, make the PET data more quantitative, make the PET data less noisy, be able to even correct motion correction, because motion is a big issue for these two types of emergent PET detectors, PET technology, because the crystals are so small, we're now getting really down to almost 1 millimeter in terms of spatial resolution, so motion becomes quite apparent. So there are lots of work that we're doing right now to be able to correct motion. But I'm going to kind of talk a little bit and end here with what we're trying to do on the other side of analysis. Now that we've had noise-free attenuation correction with MR, and now I'm pulling out a PET image and trying to do some modeling. As you know, if you're trying to do kinetic modeling on PET, you do require an input function. Your input function is coming from blood. So you have to do serial blood sampling over sometimes, depending on the tracer. If you're talking about something like TSPO, you're talking about 3 hours of scan, sometimes 90 minutes. So idea here is that we're trying to get away from being able to use blood information that we sample manually or automated from the patient and sample it directly from the data. I'm going to demonstrate what we've done so far, being able to do this image derived, so deriving this from the PET data. This is, again, some work that we did with Siemens, done by Praveen, who was a PhD student at the time, now a postdoc, and Lumen, who was a master's student, or PhD student at the time, sorry, and now I'm working at Siemens in Vancouver. At the time, we worked together to develop this application that's on the Siemens marketplace. Anybody that has any Siemens MCT can actually download this and use it. So this idea here is to be able to get away with doing arterial blood sampling from the patient and essentially driving that from the PET data. Again, this is work that was done at PET MRI, so we're using MRI as a cheat. The MRI here is just to be able to localize the arterial blood vessel, in this case in the brain. And then essentially it's an ROI, and essentially then use that, map it over to the PET data. It's PET MRI, so that's, again, easier for us to do the registration and then pull out your blood information. We've done this on a pig model just to demonstrate that we can pull this out even at vessels as small as 4 millimeters. That's the size of an adult pig vessel. And it shows very nice correlation to the reference or the silver standard, gold standard, that should say arterial input function. We've done this also in human healthy subjects and applied this to frontotemporal dementia to demonstrate that we can get really nice parametric information about the glucose distribution in the brain. And the take-home message here is that this is actually kind of giving us a little bit more information than, say, standard optic values or SUVs. The effect size, so the size you see in terms of comparing a patient group to a control group, and this we've shown this in FTD, is much larger in terms of seeing that difference compared to what if we did this just by the standard reference region SUV. And this is very important when we move to tracers that don't really have a good reference region or tracers that do metabolize. So we're working on trying to figure out how to do this for tracers that do metabolize. But I'm going to end here for time's sake, and I want to get back to where we started from, which is a problem of neurologists understanding man itself. I want to tell you that we've come to the point where we have technologies that are actually allowing us to do this. We've started to do some of this work. I think we have exciting times coming ahead at the BIC. And I'm sure that Professor Rosanetto will tell you some of the other stuff that we're doing that we are hoping, and that anybody in the room that wants to collaborate with us, we're happy to collaborate with you. I'm going to make one appeal. I'm shameless in that case. I'm here in Nigeria. There's one PET CT in a cancer center in Nigeria that only does FDG. We're really trying to see if we can do more with that. I came from Nairobi. They have 4 PET scanners now in Nairobi, the 4th one being installed soon. They have 2 cyclotrons. They're really appealing to the world to help them figure out how to get the cyclotrons to start producing tracers. They can't get a hold of the flow beta pair or of any of those amyloid tracers that we have down there. They're having issues being able to get it from GE. So I'm just throwing it out there for anybody in the room that if you want to help, reach out to me. We're trying to do some of this fantastic work also across the world. Thank you very much.